Okay, we will continue for proper and effective skill documentation for the clinicians on page 2 for RNs and LPNs. So this is page 2 for your skill nurse visit note on Netsmart and Devro. In order to ensure proper, effective documentation with best practice, for best practice. Page 2 talks about respiratory. So we will focus on that. It has a respiratory section, the skin, vascular, endocrine, GI, GU. So we will focus on that. To start with, the documentation on page 2 on Netsmart and Devro, it asks you under respiratory, is your client on any mechanical assist pertaining to ventilator, CPAP, BiPAP, VPAP, and if it's not applicable, you're gonna click not applicable. If your client is not on any of this, you're gonna click no. Where it says mechanical assist, you're gonna click no, and you're gonna click not applicable because your client is not on any of this. If your client, let's say, is on a ventilator, then you cannot click not applicable. That would create a discrepancy. If your client is on a ventilator, then you gotta click ventilator. Okay, and you make sure you click yes. If not, if they're on a CPAP, then you click CPAP. If they're on a BiPAP, you click yes. Any mechanical assistment ventilator, either ventilator, CPAP, BiPAP, VPAP. Okay. The most common ones are your CPAP or your BiPAP. And then if they're not on any of this, you click whichever one applies, and if they're not on any of it at all, you click no, and you click not applicable. They're not on any mechanical assist. And if they are, you click yes, you click which one, let's say it's a ventilator, then you give the ventilator details. You know, the ventilator name, the type of ventilator it is, and you give the ventilator details in terms what type of ventilator it is. Okay, you write that here in order to describe and identify the type of ventilator it is. You got to write the details, what type of ventilator it is, what are the settings and things like that. Mainly what type. If it's trilogy, and your setting is SIMV, whichever one, you document, you will know your ventilator details. When a patient is on ventilator, you gotta know the details. You gotta know the details for that a particular specific ventilator, and you gotta write your details here. Hours per day on mechanical assist. If it's a ventilator, you gotta put your time. Let's say a patient client can be on a ventilator. How many hours during the day do they need to be on the ventilator? If they are weaning the client of the ventilator, sometimes they'll do a trial period. The trial period will be that the client can be of the ventilator for an hour. For an hour, you know, in order to be able to participate in other activities of daily living. You know, whether it's for them to take their bath, to take a shower, to do anything. If they are able to be off that ventilator for 1 hour, then you can put that the client doctor's order, because you will have the doctor's order that will say, okay, the patient or the client can be on the ventilator 23 hours during the day, and they can be in a 24-hour period, they can be off the ventilator for 1 hour. Then you can document that the client can be of the ventilator for 1 hour, and you write the specific doctor's order. Like if they have to take a bath, if they have to take a shower, if you have to do other things with them. Let's say you have to do physical therapy to assist them in order to make sure that they are, they retain their mobility. Uh, Anything at all, like, they're to maintain their mobility, that they are active, that they are mobile, or to regain uh their mobility. Then you can document that here, because sometimes a client can be off a ventilator for 1 hour or 2 hours in a 24-hour period. They can be off of it. The doctor will give you specific orders. So you can even write the doctor's orders here. Orders is that the client can be on the ventilator for a set of hours in a 24-hour period, and they can be off the ventilator for an hour or two. And whatever the doctor's order says, you just be specific, because here it is asking you hours per day on mechanical assist. Hours per day. Sometimes some clients cannot be weaned off a ventilator at all. They have to be on the ventilator 24 hours because they cannot be weaned off that ventilator. Then if they cannot be weaned off the ventilator at all, then you gotta write, 24 hours per doctor's orders. And let's say your client is not on a ventilator, your client is on a BiPAP or a CPAP. And then, sometimes the doctor will give you orders where they have to use the BiPAP or the CPAP during the day PRN. If they can use the CPAP or the BiPAP during the day PRN, you can write, daytime PRN. Okay, it depends. And some clients, they use their BiPAP or their CPAP at night, and you can write nighttime, whatever, 12 hours, whatever the order is. Whatever is appropriate for that particular client, you got to give your hours per day, okay, for CPAP or BiPAP or VPAP or ventilator. If not applicable, you just document not applicable. However, you got to put your hours here. How many hours during the day they have to be on any of this? You got to document your hours here according to doctor's orders. And you give the detailed information in terms of what type of machine it is. Currently in use, ventilator flow sheet, and I will show you how to populate your ventilator flow sheet. Currently in use, if a client is on a ventilator, you gotta populate your ventilator flow sheet. You gotta click yes, and I will show you how to do that in a different training, how to populate your ventilator flow sheet. So if you tell me the client is on a ventilator, you got to give me the details of the ventilator, the doctor's order, how many hours a day, whether they can be on or they can be weaned off the ventilator, currently in use, and you got to show me that you will populate your ventilator flow sheet. Okay, let's say the client is not a ventilator patient and you put no. Currently in use ventilation flow sheet, then you can put no. Okay, because they're not on a ventilator. However, they have a tracheostomy. You got to tell me the trach size, whether if it's cough or non-cough, the date of your last trach change, because you have to change your trach at least once a week, or when needed, when necessary, you got to do your trach change. And your spare sizes, you got to have spare sizes. In case of an emergency, let's say the client decannulate from their trach, you have to have spare sizes if there's a decannulation, and you got to document the size. And the last time you change your trach, okay? At least once a week. Let's say you did a trach change today, you document that you did your trach change, and then if there are spare sizes in the home, the current trach size, you can put whichever trach size that the client has on. The spare sizes is usually smaller than the current, because the spare sizes is usually smaller is in other, let's say the clients decannulate and the stoma starts closing on you. Okay. So the spare sizes usually are smaller size than the actual trach itself because of the condition of the stoma. If the client were to decannulate during your shift. Uh, and then stoma side, you got to document if it's dry and intact. The side is very good if it's dry and intact, there's no issue. If there's some redness because of irritation or inflammation, because sometimes the trach color itself can cause inflammation, irritation, and you might have some redness there, which we don't want. However, if you have some redness there, you got to document that, and then you will do your best to kind of resolve that, because that's a sign of irritation and inflammation. And sometimes it is that we want to prevent this. However, if it's there, then you document that that is there. We don't want any excoriation or drainage. We don't want that. However, if that is there, if there's excoriation or drainage, you gotta document that. And if you have this, you gotta even notify the doctor, because just notify the doctor to see what is the recommendation from the physician, and if they'll give you any new doctor's order. It depends on how severe it is, which we never want. The patient even might have to be on, they might even prescribe, an antibiotic or something, depending. And also depending on the age group, doctors will give you orders, make certain decisions depending on the age group and the severity of that condition. We don't want this though. If we do proper trach care like we are supposed to, we're not, however, sometimes things happen. Let's say if we are not always there, a patient is on a trach and we are not always there, whatever causes it, we just got to resolve it. However, we want it to be dry and intact. Sometimes, the redness might be mild. It's not severe. It's not too bad. If it's there, though, you got to document that. And if it's not, and if there are other issues within the stoma side, if there are other issues, you can document that here. If there are no issues, you don't have to document that. If the client decannulated during your shift, you can either click yes or no. No if they did not decannulate, and yes if they decannulated. And if they decannulated, then you have to put your time that they decannulated. If they decannulated, you gotta put your time. You gotta put your time if they decannulated. Okay, you gotta put your time. Whatever time is appropriate for you, you put your time of the decannulation. And if a client decannulate, you have an emergency situation. You have to think fast and quick and to get this resolved. And you got to use your clinical skills if there's a decannulation on your shift. And when you recannulate, you got to document if you recannulate with difficulty or without difficulty. Okay? And then all the steps that are necessary when you do a recannulation. All the steps in terms of a clinician. I will not take the time to describe it here because you already have that clinical skills. Everything has to be sterile. In an emergency situation, you got to use your aseptic techniques. You have to use your aseptic techniques, and you have to use sterility. It has to be sterile. It has to be a sterile procedure. And then you do your best. Okay, and then when you recannulate, you gotta document which size that you use. Okay, and did the patient tolerance, was it tolerated good? If not tolerated, you gotta put a comment to why was it not tolerated. Let's say for whatever reason, let's say you didn't act quickly. You didn't act quickly enough, and the stoma closes on you, and you're not able to recannulate this patient, and you have to call 911. Okay, then you can put not tolerated, and then you document your nursing interventions. Let's say if you waited and the stomach closes on you and you're not able to recannulate this patient, you would document and comment here, 911 call and everything else. That is, needs to be documented. If it was tolerated, you're recannulated, you use aseptic techniques, sterile techniques, because everything has to be sterile when you do this, then you can document. Okay. And you already have your nurse's skills in terms of how you do it. So we don't have to take the time to explain it during this part of the training. And then number of times cannulated during the shift. You gotta document the number of times the patient cannulated on your shift if it's a yes. The number of times, okay? If you're unable to reinsert, let's say you're not able to recannulate, that's when you're calling your 911. You got to put it here and you call 911. However, and when you call EMS, if you're not able, you should be able to, if you're acting quick and fast enough, you should be able to regain and maintain that airway, because you want to maintain and regain the airway in order to keep the patient alive and safe, in order to save a life. In order to save a life, you got to keep the airway patent. Okay, so if for any reason and you call 911, this has to be quick in order to keep that patient alive. Okay, and you already know that. And EMS was notified, yes. Let's say you were able to recannulate the patient and you didn't have to call EMS, you can click no, they tolerated it. And then you document whatever is appropriate here, whatever pertains to your client. Let's say there was no decannulation on your shift. Then you click no. Then you don't, once you click no decannulation, you don't have to do any of this. You only, if you click no, you don't have to put anything here. It's only if you click yes. No documentation is needed here. It's only if you click decannulation. Okay. And if it's only a trach patient, if you put the patient, that is why it is important to document whether the patient is a trach patient or not. If you click no that the patient is not a trach patient, then you don't have to do any of this because you don't have a trach. And if it's a tracheostomy, if it's a yes, you gotta so what type of trach it is. You gotta know what type. You gotta tell me what is the type of the trach and things like that and all the details. If it's a no, it's a no. Then you don't have to document anything here. And then respiration. Let's say the patient is not on any mechanical assist, it's a no. The patient is not on a trach, it's a no. Then you can click no, no. And then now your focus is gonna be on respiration. You're gonna document whether their respiration easy and unlabored. If it's easy and unlabored, that's what you want. That's normal. Okay, then if it's not easy and unlabored, you have a labored breathing, there's difficulty breathing. And then let's say you have retractions. It can be mild or it can be moderate, it can be severe. If you have respiration that is labored, you have retraction and you have severe, this patient is in serious respiratory distress. Most likely, you're gonna have to kind of do your implement your nursing intervention, following your doctor's orders, doing the necessary treatments, and if you have to do nebulizer treatments, whichever medications you have to administer to that client, you have to administer your meds, do your NEBS treatment, whatever other treatments, as long as you are following doctor's orders in order to stabilize this patient. If you are not able to stabilize a patient in a timely manner, and you using your clinical skills, you're not able to stabilize this patient in a timely manner. And once you're dealing with respiratory, you have to think quick and fast. Then most likely this will be a 911 call. You don't even waste time calling the physician. because the physician's office is going to tell you to call 911 anyway. So that's if it's you have retraction and it's labored and it's severe. However, if it's mild, then you can definitely stabilize the patient unless the patient deteriorate or decline. There's a medical decline. The patient start, as a clinician, the patient starting to really decline, being a medical decline, and things are not good. So if it's mild and you're able to stabilize the patient with treatments and NABs, other treatments that are prescribed on your physician orders, and you stabilize the patient and you reassess, you listen to their lung sounds, and their lung sounds are good. As long as you stabilize your patient, we're good. And sometimes the respiration can be shallow, it can be shallow. Sometimes it can be shallow and you don't have retraction and it's mild. This is not too bad. You just got to continue to do your assessment. If there's grunting, grunting is not shallow. And then you have like wheezing, or you have crackles, rhonchi, you have rails. You shouldn't really have all of this at one time. However, if you have some of this, you have nasal flaring, there's flaring. You have panting, that's like distress and things like that. You have to follow doctor's order to stabilize the patient, use your nursing skills, give the medications that needs to be given, and in a timely manner. And if you're not able to stabilize this patient in a timely manner, and the patient is in a medical decline and deteriorating on you, then you know when to call the doctor and when to call 911 EMS. Because with respiratory, you have to be very careful with that, because you are there to save a life. You are there to stabilize a patient to the best of your ability. The goal is to stabilize that patient where you don't have to call the doctor or 911 EMS. That's your goal. Use the physician order that you already have, give them their meds, do the treatment. That's your goal. However, sometimes you have to do what you have to do, which is calling the doctor or even a 911. And if, let's say it's easy, your respiration easy and unlabored, and all of this is good, and then all of your lung sounds are clear. Your lung sounds are clear, okay? Sometimes it can be diminished. That's okay, that's okay if it's diminished and the person is not in any distress. It's easy, it's unlabored. Your pulse ox, when you do your pulse ox, the numbers are good. They are within normal limits. There's no shortness of breath. There's no difficulty breathing. Their skin color is good. They are not cyanotic. They are not pale. They are not turning gray or anything like that. Then that's good. It's when you have, abnormal breath sounds, crackles, rhonchi, wheezing, or rails, and then you have some of these happenings here. Then you know when to use your clinical skills and to do your proper nursing interventions and implementation, and based on your assessment and you following your physician orders. Okay, so this is what we want. We want the respiration easy and labored, and for the lung sounds to be clear. Even if sometimes if it's diminished, like I said, if the patient is good, pulse ox is good, everything else is good, then we're good. If there's no cough, you document there's no cough. If it's a productive cough, if there's a cough, you want it to be productive, that the patient can, spit out their own phlegm. They are able to spit out their phlegm. You don't have to suction them. So when it's productive, sometimes it can be productive if it's not enough, if they're not spitting out enough phlegm and there's congestion, they have abnormal breath sounds. Sometimes you have to do the chest PT, and other thing you have to do, you assist them, assist them with coughing and other things, other treatments that the doctor recommends. You don't want the cough to be non-productive. if they have a cough and they have phlegms and they cannot spit out that phlegm, then that's when you have to suction your patient. You already know the clinical skills. Use your clinical skills. So whatever applies to your patient is what you put. So however, if there's sputum, you gotta put what is this? Is it from the mouth? Is it from the nose? Is it from both the mouth and the nose? Or is it from the trach? Or is it from the trach, nose, and mouth? And sometimes it's just from the trach. And sometimes it's from the trach and from the nose. Sometimes it's from the trach. Whichever one it is. If the patient is not a trach patient, you put wherever your secretion is, okay? And then if it's not applicable, there's no cough, there's no secretions, you put not applicable. Whatever applies to your client. If there's sputum, whatever sputum and secretion, you can put whether it's thin or whether it's thick, okay, whether it's tenacious or frothy. And sometimes you have medications if the secretion is thick to prevent the secretions from being thick. Okay, you gotta document consistency and things like that. Pertaining to your client. And then if you have a client who's in respiratory distress, any kind of respiratory distress, when anything is abnormal here, you have to document a pulse ox. What is the pulse ox for the client? And you can put that under comment. You can document that the patient is in distress. If you give NEF treatment, you can do a documentation here that the client is in distress and whatever treatment that you did, intervention, nursing intervention, implementation, you will document it here. You can do a quick note here and you will also put more details in your SN notes on page 7. And then over here, it asks about parameters. Some patients on their care plan, service plan, doctor's orders, their PPOT, the doctor will give you a parameter for pulse ox. The doctor will tell you. And if you have a parameter for pulse ox, let's say, you got to put your high parameter here. The highest a pulse ox can be is 100. The highest it can be, and it shouldn't be no lower than 94. Okay? Some doctors will give you orders like that. Okay, sometimes they'll even tell you 90. Some doctors will say 92, depending on the physician. Most doctors will say 94. Okay. The highest a pulse ox will ever get is 100. That is the maximum limit. However, some doctors will give you between 92 and 94. Okay. On the pulse oximeter. However, it cannot be any lower than 90. Your pulse ox should not be any lower than 90 or 92. It cannot be any lower than 90 or 92. Because if it's lower than 90, then you're calling. If you're not able to stabilize this patient with medications and treatments, following physician's orders, then your patient is declining on you. The patient is declining fast, and it's a saving a life situation. You have to save a life. And if you have to call 911 EMS, you call 911. If you don't have any parameters for your patient, all you have to do is put not applicable. That's when there's no physician order that gives you a parameters telling you the pulse ox should be this number. And if you're not sure if there's a parameter on the care plan for this patient, you can always give me a call if you're not sure, and I will let you know. And there has to be consistency. There has to be consistency on your notes for every shift for that client. Okay. And yeah, pulse ox parameters are very important. Even if you don't have doctor's order, like I say, for a pulse ox parameter, if a client is declining on you and is in respiratory distress, you have to know what their O2 sat is. What is their O2 sat? And it should not be any less than 90 to 92. Most doctors say 94. However, in general, a pulse ox should not be less than 90 or 92. Then if it's less than 90, and you're not able to stabilize that client in a timely manner, then that's a 911 EMS call. If you're able to stabilize a patient and you are able to bring their oxygen back up, then you get it to 100, 98 to 100, or whatever, 95 to 100, whichever. If you're able to stabilize that client, then we're good. That's what we want, because we are there to save a life. If the patient is on respiratory distress and they use oxygen, even if the oxygen is PRN, you want to give them some oxygen. Okay, if they are desatting on you, if their sat is dropping, if their saturation, O2 sat, their oxygen is dropping, you want to give them some oxygen as well. Okay, so you can, that in order to prevent you from calling 911 as part of your treatment plan. Even if the oxygen is PRN, you want to give them some oxygen. If they're not on oxygen, they don't have any oxygen in the home, then you can click no. And if you're giving oxygen, you gotta say, is it nasal cannula, or is it a mask, or is it through a trach? And then you gotta document your liters per minute. And is it intermittent, which is PRN oxygen, or is it continuous? You gotta do your proper documentation here. However, anytime a patient is in any kind of respiratory distress, let's say whether they are wheezing, because respiratory is a life and death situation, you want to stabilize your patient quick and fast. If they are wheezing, you put that they are wheezing. You got to put what is their O2 sat. You got to put it here under comment. What kind of treatment did you do in terms of following doctor's orders? Whether giving them an PRN albuterol, scheduled albuterol, whether you had to do chest PT, vest PT, whether you had to suction, if they have a trach or no trach, whatever you had to do, and then reassess and listen to their lung sounds. Make sure by the time you do all this treatment and you reassess them, they are clear. They might be clear and slightly diminished. As long as it's unlabored and it's easy, then you're good. Then you stabilize your patient and you save a life during that shift. In parameters though, you have to put something, whether you put numbers for parameters or you put not applicable, you have to put something there. Anybody, an auditor who's doing an audit or wherever your charts find itself, they know there was no doctor's order. And when you are not sure, you give me a call and I'll let you know what's on the service plan or doctor's orders. And then you should also have doctor's orders yourself in the care plan. However, when you are in doubt and you're not sure, you can give me a call or send me a text. So that's for respiratory. Never send me document that a patient is in some kind of respiratory distress, whether it's crackles, rales, bronchitis, and wheezing, and you didn't do a pulse ox on that patient. That's not safe. You have to have a pulse ox and let us know what is the O2 sat on that patient. Because you can have a patient in distress, and when you put a pulse oximeter on them, their O2 sat is less than 90%. You have to restabilize that O2 sat and bring it within normal. And let's say if you're doing everything you can and you put your pulse ox on and it's giving you abnormal reading, sometimes you can put it on a finger and the reading is abnormal because the hand is cold. You got to warm up the hand. You got to do a warm up and put the, because sometimes you can get a false reading, or you got to switch hands and put it on a different hand, put it on a different fingers, because sometimes pulse ox will give you a reading that is not accurate, that is inaccurate. If the client's hand is cold, you got to warm it up. You got to switch fingers. Okay, that's another thing about pulse ox. And if you've done all this troubleshooting and you're getting abnormal readings, then you would have to call 911. You would have to call 911. However, we have to have a pulse ox reading if your client is in any respiratory distress. If their lung sounds are not clear, it's not easy and unlabored, there's any distress, we need to know what is the pulse ox and what is your nursing interventions in terms of you following physician's orders, calling the physician, or even calling 911, using your clinical skills. And then you document it here, you document it in your nurse's notes on page 7, when you do your summary or whichever notes that you do. If the skin, you gotta document the skin, it's whether the skin is pink, they're not cyanotic, they're dusky pale, whichever one applies, depending on the skin color. If it's a black person or if it's a white person, you know what the skin tone, what is normal. If they are flush, if they are jaundice, mottled, the skin turgor, you know how to document this. So you have to document whatever pertains to your client. However, something that is a normal is your patient is cyanotic. Cyanotic meaning your patient is turning blue on you. If your patient is turning blue on you, you don't stabilize this patient, you're gonna have a code blue. You can have a code blue. Okay. Sometimes they can be cyanotic and they are also pale. If your patient is cyanotic and pale, you're almost in a code blue situation. You don't want that. If your patient is pale, you don't want that either. Okay. If your patient is pink, is good, depending on the skin color. If they are jaundice, sometimes they can be jaundice. If they are a patient with a liver condition, they are gonna be jaundice. That's when they are kind of, yellowish on you. And if jaundice is normal for them because they have a liver condition, then we are good. What we don't want to see is the cyanotic, them turning blue on you, or both they are blue and pale. You're almost in a cold situation here. And then you got to do your proper intervention. Your skin turgor, you want it to be good. Sometimes it's fair. However, we want a good skin turgor, and you know how to do your assessment for a skin turgor. If the skin turgor is poor, that's when the patient is dehydrated, or something is not proper, you know. So you know how to document that. You got to document your temperature, whether the skin is warm. You want to document warm because this is good. That's mean the person is able to maintain their body temperature. If they are cool and clammy is not good. Circulation, there's a problem with circulation. And if there's other, you can put it here in details. In their skin condition, you can document whether it's clear, if there's bruising, whatever applies. If there's other, you can document it here. Their foot condition, if it's unremarkable foot condition, you can document. You always have to document this on the foot if it's unremarkable. If there's a problem, you have to document it here, whatever the condition might be. You have to document it here. Let's say the patient is an amputee, they have prosthesis, the skin color is not good, they have a circulation problem. You can document that here. Whatever is abnormal on the foot, you gotta document it here. You always have to document on skin and then on foot condition. You gotta document this. Okay, if it's unremarkable, there's no issue, you document unremarkable, okay? So we know it's unremarkable. If they have contractures in terms of foot condition, also you can document that here if they are contracted. Vascular access, if your patient doesn't have no PICC line or central line or peripheral line or port, if they don't have any of this, you document not applicable. If they have any peripheral, central line, PICC lines, ports, then you have to document whatever apply, and you have to put the location. You have to document the location if they have a central line or a PICC line. You have to document where it is, and you have to document the condition of it. You know how to do that. And use your clinical skill. If they don't have it, you just put not applicable, okay? And if they do have a vascular access, whether it's peripheral, central, or PICC line, you have to document yes, and then the dressing, vascular access, and then you gotta document when you did the dressing, whenever you did the dressing of that. And it's usually at least once a week. And you also have to use sterile technique. When you do your dressing change for your vascular access, it has to be sterile and using a septic technique. When you do it once a week, or you do it when needed, okay? Type of dressing that you use, usually we use an occlusive. The dressing is occlusive dressing for vascular access. So that way to prevent infection. If it's a central PICC line, if it's a port, it has to be an occlusive dressing and it has to be sterile. If it's a peripheral line, regular peripheral line, then it can be non-occlusive, even though it's better for you to have an occlusive dressing on a peripheral line. Okay, if you use any other dressing type, which you shouldn't, because you have it in a kit. When you're doing your dressing change, you have it in a kit. Everything is there for you. If you were to use any other things which I don't recommend, then you gotta document what you use. However, you should have your kit to do your dressing change. If it's not applicable, then none of this apply. None of this apply. All you have to click is not applicable. For your endocrine system, you gotta write whether the patient is a diabetic or no. If the patient is not a diabetic, you put not applicable. If they are diabetic, whatever applies during that shift, you document whether the patient was hypoglycemic, hyperglycemic, or they're on an insulin pump. Did you have to do were there any orders for you to do ketone checks or any other? Then you document your details here by clicking other whatever you have to click here if you have to do anything. If they're not diabetic, then you click not applicable and that's it for that section. For GI, you got a document on GI for every patient on every visit, for bowel, whether the patient is continent or whether they are incontinent. Okay, and you got to write when they had a last bowel movement. If you don't know when they had a last bowel movement, let's say you didn't work the day before, or this is not a patient that you see every day or all the time. If you don't know when the bowel movement was, then you can put unknown. However, for best practice, it is good when we know when the patient had a bowel movement, because you want to make sure your patient is not constipated, they don't have a fecal impaction, and there's no bowel obstruction, especially a small bowel obstruction, because a fecal impaction can turn into a bowel obstruction, and it can turn into peritonitis, which can be fatal. With peritonitis, a patient can be hospitalized for months, for weeks, and they can even die with peritonitis. So that's why you don't want no constipation that is not resolved. You don't want no bowel obstruction, which is going to end up into peritonitis. Okay, and your patient is going to become septic. They're going to have septicemia. It's going to get too complicated. So that's why some patient doesn't have a bowel movement every day, which is good. Some patient have a bowel movement twice a week or every other day. However, it's not even good for a patient to have one bowel movement for the week. One bowel movement for the week is not good. You need to have at least 2 bowel movements in a week. At least 2 to 3. Okay. Some patients have a bowel movement every day, more than 1 bowel movement every day. Sometimes, more than, however, you want to make sure your patient is not constipated and they don't have no fecal impaction and there's no bowel obstruction. That can even lead to peritonitis that can become fatal and for them to be hospitalized for an extended period of time. And then you gotta do your abdomen, whether it's soft hands, you gotta do that, your documentation. If they have a colostomy, ileostomy, you document what it is. If they don't have it, you put not applicable. If they have a colostomy, ileostomy, you gotta document the site. It clean and dry with no excoriation, whatever, with no inflammation or irritation if they have an ileostomy or colostomy. If they don't, you don't have. And then for your bowel sound, you always have to check on bowel sounds because that's part of your skill requirements during each visit. And then vowel sounds have to be present on all 4 quadrants. If you don't have vowel sounds on all 4 quadrants, something is wrong. You have to call the physician. The vowel sound can be hyperactive, which is fine. Sometimes, if the patient eats, some good food, they can have hyperactive bowel sounds, or sometimes if the patient is hungry, they didn't eat it, they can have that stomach doing its thing. You don't even need to do a stethoscope because they have to eat. If that bowel sound is hyperactive bowel sound is not too bad. It's either the patient ate a lot of food or they are hungry. Okay, sometimes you have that. Hypoactive bowel sound is not good, meaning they could be constipated, have a bowel obstruction or fecal impaction. If you have that, and throughout your shift, when you do your reassessment, it's hypoactive and you don't have bowel sounds on whole four quadrant, anything that's if it looks abnormal to you, then you have to call the physician and let the physician know. And if your patient, let's say for a week, had a bowel movement only once during the week, because by the fourth day, if you don't have a bowel movement, it's considered constipation. Because like I said, you gotta have 2 bowel movements in 7 days. In 7 days, you gotta have 2. If like the fourth day with no bowel movement is considered constipation, and the doctor has to be called. The doctor has to be called. Okay. And sometimes the doctor will make their recommendation when you call the physician by the fourth day if your client doesn't have a bowel movement. If by the third day they have a bowel movement, we're good. We should not have a patient like for 7 days, they only have 1 bowel movement or they had no bowel movements at all. That's not good. That's how we're going to end up with a fecal impaction or obstruction, which we don't want, and the peritonitis. Okay. Nutritional intake, if your patient is NPO, you can put NPO. If they are on supplement, you can put supplement. If they're on supplement, you can put the detail of the supplement. Okay. It can be Ensure, it can be Boost, whichever one. If they are on a restricted diet, you can put the restriction. If there's no restriction, you don't have to put no restriction. If they can eat regular food, all you have to do is regular food, okay? They can be NPO, nothing by mouth. That's mean it tells everybody they cannot even take their medications by mouth. If a client is NPO, you have to make that clear, meaning they cannot have anything by mouth, even medications, okay? And then if they're on a formula, you got to document what formula it is, and you can write the physician's order. You can put the formula name, the bolus. If it's bolus, you put bolus. If it's mLs per hour, you put mLs per hour. You can write the doctor's orders here, and you make it clear to everyone. And if they're not eating by mouth, you cannot assess their appetite because there's nothing to assess because they're not eating by mouth. Okay, you can put not assess if they are NPO. If they have fluid intake restriction, you can put restriction and you have to write how many ml of restriction. You cannot click on restriction and you don't write the doctor's orders because the doctor is the one who gives you the restriction. You have to write how many mLs, how many liters of fluid restriction, how many mLs is the doctor's order. If there's no restriction, then you click no restrictions. You can have a patient on a gastric tube, or it can be on both on this. Okay. Okay. That's that over here. Or you can just click on this over here, indicating and they are NPO. That's mean nothing by mouth. Even medication and their feeding is, through the GJ to the tube. If they have a Faro bag and things like that, you can document Faro bags and you document other things here to be very detailed and have proper documentation. And sometimes your patient can be on a G tube. However, they are also on a puree. If they're on a puree diet, you can write that here. Okay. On a puree, and they have the G tube. The G tube might be for medication or whatever, or it might just be there. However, they are able to have a puree diet. Then you have to do your aspiration precaution. Pureed mechanical soft, you have to do aspiration precautions. Make sure there's no choking hazard. Things like that, you got to do your precautions. So then you don't click NPO. If they're on a puree, they're not NPO. They can have a G tube and be on puree and they're not NPO. Okay. The only time you click on NPO and this is if they cannot have anything by mouth, and that's also with medications, and you make that very clear. And then your tube size, you can write your tube size here. And then how do you placement verification? How do you do your verification to make sure that the tube is intact, that gastrostomy tube or GJ tube to make sure how your tube is intact. There's no issue. Placement verification for each shift, you got to document here. How were you able to determine that the tube was secured and in place? Whether you have to say your balloon is intact or you did it by aspiration, whatever in terms of gastric content, whatever you have to put something in here if your patient has any tube, has any NGT, any tube at all. You have to put how you were able to verify placement. If you don't put anything here, that's mean you did not verify the placement of that tube. And if you leave the home, anything happened with the tube or the client, then it's gonna be a problem. That's when you didn't verify your placement of that too, okay? So it's very important that you document for your shift that you did verify that it was in place and it was secured. So when your shift ends, if something happened to the client, you will not be held responsible. Skin condition, dry and intact, you know how to document that. And if there's anything abnormal, you know how to do your proper nursing implementation, intervention, and document everything if there's anything abnormal. You don't want to see the excoriation or drainage or anything like that. You want it to be dry and intact. It might have some redness and inflammation, and you'll try to resolve that. That's good. The last time the tube was changed, you can document the last time the tube was changed. And you know, it's done by the physician, the GJ tube, some of them are changed every 6 months. You can document that here, and the tube change details, you can document that here also. Okay, for your NGT or GT or GJ tubes, you know, you can document that here. Tube change details. If it's changed by the GI doctor every 6 months, whichever, whatever you want to document here, okay? And then if you have a colostomy, ileostomy, you document here. If anything is abnormal, excoriation or drainage, you got to put something under comment here, and you also got to document it on your skilled nurses note on page 7. Genital urinary, I see some clinicians only mark unremarkable. If an auditor pick up your chart, that would not be good for you to just mark unremarkable and then you don't document anything else. Or anyone who pick up your chart for them to read it and see that you put for genital urinary, for GU, genital urinary, you only click on unremarkable. You have, if it's unremarkable, you can click on unremarkable and you can put urine color, you can put it's yellow. And then the clarity is clear. If it's not clear, you gotta document whatever it is. If it's unremarkable, it's gonna be yellow and clear. Bladder frequency, some patient urinate every 3 to 4 hours. Okay, you gotta be able to void and clear your bladder at least every 4 hours. And if the client is not able to void and pass urine at least every 4 hours, then the doctor will give you an order to straight cut that patient or put an indwelling catheter. Okay, so your bladder frequency can be every 3 to 4 hours. If the patient is able to void and pass urine, and your odor, if there's odor, you can put yes or no. You always have to click something on here. Okay, if there's odor, you might have, if yes, it might be a UTI. Then you have to call a doctor and get orders to rule out UTI, and the doctor will give you orders if you think there's a UTI. If there's sediment in the urine and there's odor, it's definitely most likely a UTI. You got to document all of that, okay? If the patient has diapers, you click yes or no. You have to document whether yes or no for this section here, okay? And how many diapers did the client use? You put how many diapers here that the client used, okay? For it to be unremarkable, everything has to be there's no. Odor urine is no, sediment is no, okay, for it to be unremarkable. If something is not normal, you don't click on remarkable. Unremarkable means everything is within normal. If something is abnormal, you cannot click on remarkable. You leave that on click, and you can put there's odor in the urine. The urine is foul smelling, and we got to rule out UTI. That you call the physician, you got orders if there's sediments. things like that. And if the patient is not able to void on their own at least every 3 to 4 hours, you got to call the doctor. And most likely they'll give you an order to do either straight catheterization or do an indwelling catheter. If the client has no catheter, you can click no. If the client has a catheter, you got to put the catheter size, okay? The catheters have different sizes. If they have a catheter, we gotta know what is the size of that catheter. You have to document it here. Don't just click that catheter and then you don't put what size it is. Okay, and what type of catheter is being used? Indwelling catheter is the regular Foley catheter. Intermittent is the one that we do the straight cat. If we're doing straight catheterization on the patient, you gotta document the doctor's orders here. If it's every 4 hours or every 6 hours, sometimes you'll say every 4 and sometimes you'll say every 6. You gotta document that here. If there's no catheter, you just document no, you don't put anything else. Sometimes it's a suprapubic catheter. You got to click yes or no. You got to click on this for every patient. Catheter, yes or no. Suprapubic catheter, yes or no. And if there is, you got to give the details. If they have a catheter, when was the last time the catheter was changed? You know, you have to do it at least once a week or as needed, when needed. Okay, if something happened to the catheter, something is abnormal, you got to use your clinical skills. However, it has to be changed at least once a week. A catheter care, I mean, no, I mean, the catheter care has to be done at least once a week. And sometimes doctors will tell you to change the catheter itself. Sometimes it will say once a month. To clarify, date of the last catheter change at least once a month. Let me clarify that. Some of them is every 2 weeks. Sometimes if the client is a quad, I've seen orders when the client is a quadriplegic, the doctor will write every 2 weeks. The minimum is every 2 weeks, and the maximum is once a month. If they have an indwelling catheter, it has to be changed every 2 weeks or at least once a month to prevent infection. Okay, so let's clarify that. A catheter, there'll be doctor's order. This is not something you do on your own. There'll be doctor's order telling you whether you should do it every 2 weeks or once a month. However, if you don't do it, the best practice is once a month. Because if you change a catheter too frequently, because it's a foreign body, you're introducing a foreign body, it puts the patient at risk for infection. The less you do this, the less the patient is at risk for infection. So sometimes it is required. It is required for you to do it at least every 2 weeks or once a month. A catheter should not remain for greater than 30 days because if it does, it can also put the patient at risk for infection. You just follow your doctor's orders. So when it said the date the catheter was changed last, it tells everybody when it was changed last. So the clinician and everybody will know when it needs to be changed next. It tells people when it needs to be changed next based on the doctor's orders, whether it's every 2 weeks or once a month. So you have to put that detail here. If they have distension of abdominal distensions, yes or no. If they don't have any distension, you have to always click on this. It's yes or no. Every yes or no question on Netsmart and Devro, if they give you a yes or no question, you either have to click yes or no. And if you click on yes, you got to document all the details. If it's no, then you don't have to document anything else because it's a no. Anytime you see yes or no questions on Netsmart and Devro from page 1 to 7, you have to click on either yes or no and then do your proper documentation. And here it asks you male circumcised. If it's a female, you're going to put not applicable, okay? Because it's a female. If it's a male, you got to write whether if the male is circumcised, yes or no. You got to document on this, and then you got to save your note. When you're done with your page, because you don't want to do all that work and then you don't save it. After you've done all this work and this good documentation, you got to save your documentation. All right, and that is it for page 2. I take my time to explain this in great details. So that way we can have proper and effective clinician documentations. If you have any questions, you can always give me a call, or it's better even if you send me a text message. Just don't use clients' names because of HIPAA if you send me a text message. And that's all for this presentation. Thank you for your time.